Oh, I can start.
Yeah.
Okay, so I have
wait.
one.
Oh, I have to go.
He has to go.
9 o'clock.
Okay,
Yeah.
he has so
See you. Bye.
my adorable assistant has now left me. So now you're stuck with me. But I will do my best to hold the fort until my mom comes in. My name is Laura. I'm the CEO of VMD Hypoallergenics. And today we are talking about psoriasis and eczema. And before my mom comes in, who is our resource expert for the day, I wanted to share with you some of the products that we make that are sort of standard recommendations of a lot of dermatologists for eczema and psoriasis care. What we always say, always, is start with a patch test. Is that true? I think we always say start with your dermatologist first. Make sure you get a proper diagnosis. You're not self-diagnosing. There are many skin conditions, and a lot of them look alike. So even experts can sometimes misdiagnose because things do present very similarly. So make sure you get the right diagnosis, eczema, psoriasis, and then probably you're going to be asked for a patch test because allergen avoidance is extremely helpful at avoiding flare-ups. Basically, these are both inflammatory skin conditions. So anything that can prevent inflammation is what you're looking for. And prevent allergic or irritant reactions, for example. So what is normally recommended is very, very allergen-free everything, right, from head to toe. Essence Clark Wash is normally what we would recommend, and Essence Conditioner. Clark Wash is nice because it's also great for seborrheic dermatitis on the scalp, right? So it's very, very gentle. You would use it scalp, hair, body. It's gentle enough for even, the most sensitive parts of your body. For those with severe sebderm on the scalp, a nice technique that my mom likes to recommend is put Boo-Boo Balm first through the scalp, comb it through, and then do your shampooing and conditioning and rinsing. So normally we would start with the most basic things, which is a hair and body wash and conditioner that are allergen-free. So no fragrances, no dyes, no preservatives, no formaldehyde-releasing preservatives, no parabens, no allergens. And these are free of all 109 allergens, which you can see from the VH rating there, which says VH minus 109. And then for facial cleansing, I actually don't have my Red Better cleanser. I just ran out. COVID, by the way, has affected a lot of things, including our stock availability. So I appreciate your patience, y'all, and I promise we're working really hard to get stocks normalized. But it really isn't just us. It's a lot of our suppliers have been hit hard too. So we're trying to be understanding with them and plan better. But okay, so again, shampoo and conditioner, Essence Clark Wash and Conditioner, and then usually we would recommend the Moisture Rich Cleansing Milk or the Red Better Cleanser, both of which are anti-inflammatory. Sorry, there's music. I don't know where that's coming from. Mom? It's really loud. I'm sorry. That's okay. Sorry. Okay, so again, Essence Clark Wash Conditioner. Cleanser would be Red Better Cleanser or Moisture Rich Cleansing Milk for the face. And then these two conditions, again, anti-inflammatory, dry skin, very sensitive skin, tends to get breaks in the barrier. We would recommend either the Essence Hand and Body Smoother or the Mommy Coddling All Over Lotion, both of which have virgin coconut oil and monolaurin, which is really important for barrier repair, moisturization. Fatty acids of virgin coconut oil are native to skin, and they both have disinfection. Virgin coconut oil on its own and monolaurin especially. And again, because layering is so important, not just for sunscreen, but for protection of the barrier, we would recommend after your sort of all over moisturizing coconut oil. And we have a coconut oil that's pure, which is Noah oil, which is organic, cold pressed, virgin coconut oil We also have Oils Well, which is, someone was asking in the questions, what is the difference? Oils Well is virgin coconut oil plus monolaurin. So this is actually, if you tend to have psoriasis and eczema that needs more management, we'd recommend this over no-wood oil. But even no-wood oil is excellent. So again, you want to layer that moisturization and that barrier protection. So that would be the moisturizer and then the virgin coconut oil, and then a sunscreen like Armada Baby or post-procedure, which is inorganic or mineral. And when you have a flare, check with your doctor, but ideally you don't reach immediately for a steroid. Regular steroid use is problematic. We see a lot of thinning skin. It can get to like Cushing's disease. It's a real problem. So we've had to hospitalize some people who are on steroid withdrawal, and it's a thing. So if you can avoid it, that would be great. And we normally recommend Boo Boo Balm for flares, minor flares, itching, and pretty much anything else, like a minor cut or insect bites or minor burns. And if the flare is a little itchier, red, more angry, flare up balm, which is now called Calm the Heck Down Balm. It's a Red Better product. It's great because it's really anti-inflammatory, and it really calms skin down quickly. Cold compress as well with VCO. So there, those are the main products we would normally recommend. Clark Wash, Essence Clark Wash, Essence Conditioner, Moisture Rich Creamy Cleansing Milk or Red Better Soothing Cleansing Cream, the Essence Hand and Body Smoother, or Grandma Minnie's Mommy Coddling All Over Lotion, followed by Virgin Coconut Oil, no-wood oil or Oils Well, which has monolaurin as well, Armada Baby or Armada Post Procedure for sun protection, and it's also an additional barrier, physical protective layer. And then for flares, Boo Boo Balm or Flare Up Balm. So there, that's sort of what is normally recommended from our side, but your doctor might also require biologicals, which are certain drugs that are actually pretty miraculous when they do work, but they are expensive. So do check on your insurance, because a lot of this is covered by insurance, and your doctor can help you with that. So definitely for eczema that is chronic, a little more complicated, and certainly for psoriasis, rely on your dermatologist. These are not conditions to sort of just manage willy-nilly and guess at. You know, you're not supposed to self-medicate with these things. So on that note, I will be bringing in my mom, Dr. Viralio Rowell. She's Verm to her friends. She's a dermatopathologist. And in addition to, can you shut that? In addition to contact dermatitis, psoriasis is very, very close to her heart. So yeah, she's kind of perfect to be talking about this. She's published all over the world. She's pretty fantastic. So here she is. Say hi.
Hello, everybody. Good morning, world. Good afternoon, good evening, wherever you are as well.
Okay, let me quickly get to soap, post, Nobel. Can the Calm the Heck Down cream be used as an acne gel? We have Red Better Spot Corrector is probably better for that. But while I have her here, I'm going to jump into the hardcore skin questions instead of the product questions. And the first is, can you finally tell us what they are? What is psoriasis? What is eczema or atopic dermatitis? And what is the difference between them? This is one of the questions we got.
Okay. Those three belong in what we call inflammatory diseases. The difference is the way it's presented and the cells inside your skin that are active. So psoriasis is 25 to 25% of people will have it in their family. As one
So it's hereditary?
In part.
Okay.
Not everybody has it. Okay. Acne, in a sense, is also hereditary in that...
Acne's next week.
Next week. I keep thinking of acne. I don't know why.
Psoriasis and eczema.
And
so
eczema.
what is psoriasis?
And eczema.
What is eczema?
So I hope I explained psoriasis already. There's a big number of people who may have it, who may have inherited it.
But what is it?
It's an inflammatory skin disease where there's overproduction of the interleukins. So IL-12 and 23 and 17 and 17A. Those are the ones that we're now identifying.
What are
But
interleukins?
you don't want that. You don't want to go into the pathogenesis very deeply.
We don't want to go into the pathogenesis. Okay.
Okay. Because it goes to molecules and genes, and this is only an introduction. Let's get started first with how it looks.
There. Perfect.
All right? So, let's put aside the psoriasis. The other one is eczema. Again, eczema has a very high percentage of people who have a allergy to, or rather, have a history for either hay fever or for asthma, bronchial asthma. And those triad, together with atopic dermatitis, is what's called an atopic background. Not everybody needs to have them, but family history is important. And so, segueing to something, when I have a family history of these, I always advise the parents to bring them over already when they're early, because we can now actually help prevent, protect, and do less damage to that barrier that is very important in the treatment of acne as well as eczema. Let me give you another thing about eczema, a basic thing. Eczema is a broad term, and it can apply to many other conditions besides the atopic people. They have it early in life and they progress and become worse, but then some of them may get better and have a recurrence later on. The important thing in eczema is that there's atopic dermatitis, there's nummular eczema. Nummular are those round spots that eczematous, they're red, they're itchy, they're weepy. And so that's atopic dermatitis, nummular eczema, and eczema from contact dermatitis is very common. So those top three are the ones that are inflammatory plus an inflammation basically of the surface of the skin where bubbles appear. And then they become crusty and scaly, and then they become better. And
Okay.
they keep recurring.
So let me try to sort of break this down a little bit, right? So first things first, psoriasis and eczema are not the same thing.
Right.
But they are both inflammatory skin conditions, okay? Eczema is actually a general term, right? That is descriptive, because eczema-related conditions blister, right? They have sort of these
Bubbles first.
They bubbles. There you go. So you develop sort of these bubble type things on the surface of the skin that then crust over, get very dry, and can get very itchy. Correct?
And in the process, thank you, Lau.
Sure.
In the process, people tend to prescribe steroids. And those steroids really should be used very infrequently or for short periods of time.
Okay.
2 weeks.
Let's
to
go
a
there
month.
later, because that's treatment na. Let's just talk muna about the distinction,
Okay.
right? So with eczema, remember, it's bubbles and then crusting over is sort of the shared description of the condition. For psoriasis, it presents differently.
Dry, scaly, thick patches.
Thick patches, scales, more than the
Usually
bubbles.
starting on the scalp for many people.
Right. Sometimes you can see it in the nails, no? It starts there also.
Yeah, those are nice areas that we look at for spots and
Okay.
changes.
So psoriasis and eczema are different. Both are inflammatory conditions. Psoriasis tends to be more marked by thick scales, patches and patches of scales, starting usually in the scalp. You can also see signs in the nails. Eczema is a descriptive term for multiple things. Atopic dermatitis, nummular eczema, eczema due to contact dermatitis, and the description of eczema means those little bubbles that then crust over and get itchy. We have a question here from St. Frank Lloyd. Is seborrheic dermatitis a type of eczema?
As a rule, no. It's basically really dry flaking, of the scalp. It becomes, however, eczematous if you apply too many things that can either thin the skin of the scalp. So that's contact dermatitis due to the medications you may be using. And just remember, steroid by itself is also an allergen. We actually patch test to the steroids. within our routine trade that is from the ACDS. So,
So sebderm is not eczema.
by nature, by primary nature,
It is flaking. Is it its own condition or is it also inflammatory?
it's its own condition as well because it follows. It starts almost like psoriasis, but psoriasis has those cytokines, is what we call them, that are produced by the cells when they're stimulated in psoriasis.
Okay. So when diagnosing these conditions, right, if a dermatologist is looking at someone, when would they say it's, say, seborrheic dermatitis versus a type of eczema versus psoriasis?
By history, always, the most important thing is we always have to listen to our patient. Number one, you get the history. We get a thorough history about when did it start, how does it progress, does it come and go, and how often is that, and what seemed to trigger it, things like that.
Okay.
So history is number one. Then the second thing is we look at the distribution. Distribution of the seborrheic dermatitis tend to always be on the scalp, although there are some people who may have sebderm, we shorten it, sebderm in the face,
I get that.
on the chest as well. So,
Here it's called banker's rash, diba?
right.
Because it's linked to stress.
Right. So that's how you would do in psoriasis as well. You ask your parents, did you have any psoriasis in the family? How old were you when it got started? And what parts of the body would start the process before then it becomes more generalized and thick and patchy all over? Because there's usually a history of that. But you have to, when did I begin? Was I just a 10-year-old? Or did it actually start anew in when I turned into my 18, 19, 20, 21, 22, which is a peak age that psoriasis develops, until some people will then come at the age of 40, 50, 60 and say, I have. And in those patients, I'll always look for the history of what drugs are you taking. Because certain drugs that you may be taking internally may be the one that's making the psoriasis flare at an older age.
But for diagnosis, right? Because a lot of people will come, at least to us, right? Customer questions we get, and they'll be like, oh, I have eczema, or I have psoriasis, or I have seborrheic dermatitis. One of the first things we ask is that a diagnosis made by a doctor,
That's
or is
right.
it a self-diagnosis? And so the question I have is, a lot of this stuff can look similar, especially to the untrained eye, to a non-physician, right? So what are the things a doctor might use? You mentioned clinical presentation, history, familial hereditary factors, drugs that they might be taking.
Right.
Would you also do diagnostic tests?
Yes,
Like
definitely.
what? Like what?
Very often, we dermatologists can know what psoriasis is just based on the first two, which is history, how it started, etc., and number two, what treatments have been given, have been used for it, and how has it progressed through the years. Those are basic questions, and from then looking at the lesions themselves visually, as well as the new stethoscope of dermatologists is called a dermoscope. I can look at that skin with
She
just
loves this thing.
it's non-interventional. I just take a look at it, put it on the skin, and there are features about it that say, this is psoriasis.
But do you also do biopsies or blood tests
Absolutely.
or patch tests? Okay.
Absolutely. And the importance of the biopsy in particular is to rule out other conditions that may be aggravating the psoriasis. So, for instance, we do a biopsy and we look, of course, at the surface. Very typical. The classic features of psoriasis will be seen by us in the epidermis. But then we look into the rest of that epidermis that is thick and scaly. Are there any bubbles there? And in addition, we look at the lower part of the lesion, and if we see lots of eosinophils, is a kind of cell type that we will see in skin biopsies. If there's lots of it,
Right.
then I will have to consider an associated psoriasis incited by the drug that you're looking for. People who are taking, for instance, lithium and several of the neuroleptic drugs, they can trigger psoriasis and stay with it until you stop it.
Right. So
The other one, let me
Okay, go,
finish.
go.
The other one, so we're going deep into that, but in addition, psoriasis, we need to look at it because there are so many side things besides contact dermatitis, it can have mites in them, for instance, or fungi or bacteria. We need to look at that. That we can spot in a skin biopsy and then order a culture as needed. So you need a doctor to analyze all that.
So, sort of wrapping this all up, because obviously this is not med school or a dermatological residency. There's a lot to go through, right? Her other daughter, my sister, is in med school, so she's drowning in all this. It's a lot. But basically, eczema and psoriasis are dry, right? They look dry, but they're not just dry skin. They are inflammatory skin conditions. A dermatologist is needed to make the diagnosis. This is not something that you can kind of just diagnose yourself. Because as you just heard, there are so many factors to consider, so many things that it could be. It could be just regular inherited sort of psoriasis, plaque psoriasis, it could be drug-induced, etc., etc. So you really need a dermatologist to do it. Among the tools to diagnose the conditions are family history, how it presents in the skin, obviously the clinical manifestation of the thing, but some people, especially like her, because she's a dermatologist and a dermatopathologist who takes biopsies and reads them under a microscope, give a more accurate diagnosis as to what we're dealing with. And she often also asks for blood tests to look at inflammatory markers. And she'll often do that with inflammatory patients over years to check and see how the inflammatory markers are doing and to see if there's another infection that might be contributing. So the basic thing to learn here that we've covered so far, eczema is a descriptive term and it means bubbles and then the crusting over. It can be several things: atopic dermatitis, nummular eczema, eczema from contact dermatitis, which is why photosensitivity, which is why a patch test is so important for these two things. And psoriasis manifests as plaques and scales. And seborrheic dermatitis is neither, but it is scaly, right? And inflamed also, but a different thing. Okay, so we have a question here from Tina Marie V14. Can atopic dermatitis be only on your hands and feet?
Absolutely not. You can have it everywhere.
But is it possible?
The most common areas are what we call the extensors.
But is it possible, let's say I get diagnosed with atopic dermatitis, but really only my hands and feet are affected?
I know. More likely you have contact dermatitis.
There you go.
Because these inflammatory diseases, whether it's psoriasis or eczema, are caused by inflammation in the body, whether from this, that, or the other thing. But the important thing is that it may be a wrong diagnosis, let me put it simply. As a matter of fact, because my practice now, we have wonderful dermatologists here in the Philippines as well as abroad. But still, despite that, many of the patients are referred to me because they're not responding at all even to biologics. That's the most important thing, is look for the triggers, look for the comorbidities, look for the other things that may be contributing, because the diagnosis now for psoriasis is so easy to do and to confirm. Plus, you can actually have drugs that are amazing. Many of my patients, because of these new drugs that are targeted to the origin of the psoriasis, that's at the molecules within the skin. I can give a biologic and in a week or two, the skin is totally clear. And then we maintain them depending upon how the patient is reacting. And for I have several patients, I give the first shot or second, completely clear for as long as a year or two.
Right.
And the good news is that there's even more that's going to be coming out that reach what we call PASI 90 to 100. 90 to 100% clearance within a 2-week or 3-week period of
For
time.
psoriasis, you grade it. It's a specific thing. But let me just underscore something here, because what I think she does that is really special is she never, ever, ever thinks that it's just one thing, one tablet, one injection, one thing, and you're going to be fine, especially for inflammatory skin conditions, because there are so many factors at play. Like she said, contact dermatitis. If you get a patch test and you learn you have certain allergens, if you avoid them properly, you reduce the risk of triggers that can cause a flare. So she will absolutely focus on contact dermatitis as a possible trigger. She will look at the drugs you're taking, the food that you're eating, if it's inflammatory or not.
The sleep you have.
The sleep, if you're sleeping 7 to 8 hours a day And she works closely with psychologists, psychiatrists, and dermatologists. One that we work with very frequently is Antonio Season, Tofi Season. Doc Season, love you to death. Because he's very big into inflammation and its relationship to the brain and the skin. Sorry, this is my son again. He's making a cameo.
Yeah.
Lola's answering important questions now, so shush. Okay.
He's my swim buddy. We do laps.
So the last thing I want to say is if you're going to be managed for an inflammatory anything, you really have to look holistically at everything. Biologics, patch testing, allergen avoidance, the drugs and vitamins that you're taking, how you're sleeping, and your mental health.
One last very important thing, common also to atopic dermatitis and psoriasis, is the barrier is disrupted. In other words, what that means is that the normal barrier is a very thin, saran-like thickness or glad wrapped. That's the one that is the last layer of our skin. And believe it or not, that very thin layer is what is our protection to the world. In both psoriasis and atopic dermatitis, because their main event of action of these inflammatory cytokines is at the epidermis. So therefore, the epidermis has that barrier I was talking about, and because of either the disease itself or because of the medications that you're applying that may produce a very low-grade irritancy or an allergy, that there needs to be a barrier repair that we need to give in the treatment of psoriasis and eczema.
Okay, so again, they're not the same thing. Psoriasis and eczema. You're going to have several types of eczema. Eczema is a descriptive term. Bubbles, crusting. Psoriasis tends to be thicker, dry scales and plaques. Seborrheic dermatitis is neither, but it is also inflammatory and is scaly, usually around here and here. Eyebrows as well. And sorry, going back to the Tina Maria V14, can atopic dermatitis only affect your hands and feet? Probably not. It might be a misdiagnosis. It might be contact dermatitis to rubber, for example, in phone handles. This is very common. Rubber in your shoes. So a patch test is probably a really, really good idea. Anne-Marie Savage, are you aware of the drug Dupixent for eczema? And if so, what are your thoughts about this drug?
I think this Dupixent in particular, I don't remember the studies on it, but there are lots of studies that are being done internationally to see how the skin is affected or what are the actual pathways of inflammation. So Dupixent is one of them. I think they're terrific, but I'm not familiar with it much because we don't have it in the Philippines.
Mm-hmm. And again, what we normally do, at least what she does in her clinic, and certainly it's our philosophy in our company, it's never a one-shot deal. Even if you find a drug like a Dupixent or a biological that is excellent for you, you really still need to do that allergen avoidance. You do need to look at the drugs and vitamins you're taking. You do need that sleep. You need the mental health, and you need to eat right if you're going to keep the inflammation down. It is a whole system of it's a virtual cycle that we're looking for, right?
So let me summarize it further. On the top layer of the skin, the barrier repair there should be aided by topicals that you use that actually are occlusive and humectant, as well as anti-inflammatory. You apply it to the skin, it's like you're replacing the saran wrap of your skin with these topicals. Down the line, researchers are doing these fantastic studies that have brought out the biologics, whether it was ustekinumab, secukinumab, ixekizumab, and
really funky names.
I know they're funky names. I'd love to meet the guy
Woo!
who gives them this name. But downstream, this is the way medicine has improved. Is eventually not just the drug, but by identifying the pathways, your doctor, the drug company we work with in order to do this clinical trials after they've done what is called phase 1 and phase 2, and then go into what we call the clinical trials, randomized, and all that. And on a big number of people worldwide, I'm doing 2 of those biologics in my clinic right now because we do a lot of researches there. The important thing is, based upon that, these drugs that you were asking about, we can actually then personalize among those many drugs which one will really work. the genetics that they are doing now
Fantastic.
is fantastic. Eventually, we will really have the future of medicine is
Customized.
hopefully not COVID anymore, but it's customized, genetic, customized based upon your genes, how your genes react actually to these drugs. So,
Okay. I have one more question, and I'm sorry I skipped you earlier. Cess and poo. Is there a milder alternative to betamethasone salicylic acid? It's what I found to be effective in treating my eczema, but it always leaves very dark scars on my skin.
okay, dark scars or white scars are the effects, are the superficial effects of the use of betamethasone and other even higher potency steroids. What the salicylic acid is doing is that it removes the flakiness, the thickness, and the scaling, and it also is anti-inflammatory. Remember, it's like aspirin, acetylsalicylic acid. So it does things on the surface. But the thing is that we need more than just the surface. So there's the betamethasone, which goes into the skin itself and into the dermal layer, and addresses the inflammation there. So there's none of that thing. Yeah, so I think you're good with using salicylic acid products, but put it into a base that has no betamethasone, except to use it only for 2 weeks to 4 weeks maybe. I find many people who come to see me as a referral case already, people who've been using it for years, their skin is absolutely thin, from the use of it, especially in areas of the face. You don't want to get those dark marks or those red marks from steroid use, and you need to address the barrier that is destroyed by the steroid.
Yeah.
Rather quickly.
Steroids she's really not a fan. Steroids are wonderful. Please don't get me wrong. They're phenomenal and miraculous and absolutely necessary sometimes. However, where we get into trouble is when steroids are treated as maintenance daily things.
Exactly.
Of the several problems that happen, number one, she mentioned it, the skin becomes so thin. So now you have all these other problems to deal with just from the steroid alone before you can really address the underlying condition. So you have to now recover from the steroid use for so many years. When it's so chronic, so long, you do have adrenal gland issues. People do have to be hospitalized, and many times she'll have patients hospitalized who need to be completely darkened rooms because they're so photosensitive already. And her poor patients can be really, really desperate because they're so itchy. The flare, the rebound effect is so severe. And she really is so good about talking them through it. You know, be calm, let's stay in the dark, get away from the photo triggers and all of this. Then as they start to improve, then the patch testing comes in, then the maintenance comes in, and you have years and years and years of clarity without having to use steroids, except, in extreme cases, right? So steroids are just not sort of...
They have their uses.
Yeah,
Don't get me
they're
wrong.
important.
They're dramatic.
Yeah,
But for
but
those
not
of
for
you in
maintenance.
the audience who are listening about the use of steroids constantly for years already, you watch out and you will find not only the thinning, the barrier destruction, but in addition to that, you'll also find out that the skin no longer responds.
That's true.
The way it did respond.
That's true. So you need more and more and more and more
Right.
to get the
So-
same effect. So it's just worse, right? And there's also steroid acne. Like there's a bunch of stuff to worry about. Okay, apple rar. Love it. Can aloe vera cause allergy? I developed a super itchy rash after I took the NC-Lex. Not sure if it was stress or my shampoo that contains aloe vera. I can take a stab at this first.
Right, go ahead.
Okay, so aloe vera, strictly speaking, is not a common contact allergen published in allergen lists. However, it is probably unlikely you're using a pure aloe vera that is not in a larger formulation. In our live stream on contact dermatitis and patch testing, one of the things I really underscored is without a patch test, it is almost impossible to accurately identify what is causing the problem. Because in any formulation, there are multiple ingredients, right? And the thing that you think might be causing the problem might not be at all. It might be something else is there. And things like fragrances aren't even sometimes listed as fragrances. They're listed in other names or related ingredients like cinnamic alcohol. So a patch test is kind of really what you need if you suspect something you're using is triggering a reaction. But aloe vera in and of itself, pure. I'm sure there are case studies, anything can be an allergen, but it isn't in the latest lists that we've seen on the most common contact allergens. So I hope that helps. Okay, moving on. I promised, Soph posts, no bill. What are the essentials for mild seborrheic dermatitis?
Mild seborrheic dermatitis, number one is meditate and become less stress-free.
It's called banker's rash for a reason.
That seriously. The bankers come back during the tax session before. So number one is know yourself and what triggers. Always look for how did it start. One patient will say, I got this infection, by the way, in December. I was given antibiotics. That's a very good trigger, both the antibiotic as well as the infection itself. Or they will come and say, I don't understand this. Why do I get my atopic flare-up just before my periods, right? I very often refer to my colleagues because I maybe know something from medical school and along the way of reading, but as a dermatologist, I respect the other specialties. I'll send, for instance, to the infectious disease doctor because there are lots of fungus, normal fungus of our skin that are now resistant to even the stronger drug of antifungal. I need somebody to help me out in clearing those people. Now that they are the resistant antibiotics, do we see a lot already? Yeah. For a long time we were saying, no, we don't get MRSA here. Well, we have MRSA, MERS-strep, MERviruses.
Okay, so for sebderm, mild patch test again, because there's really nothing like knowing specifically what you need to avoid that might be the trigger. It can really be helpful. Number two, gentle thoughts, meditation, get therapy if you feel like you need it. I'm a big fan, certainly. And there are psych derms. Again, we mentioned earlier Dr. Antonio Season in the Philippines, but there are psych derms all over the world who specialize in the relationship of stress, inflammation, and skin. Get enough sleep, 7 to 8 hours. Eat right, anti-inflammatory foods.
At the proper time, the 7 to 8 hours really means 9 o'clock until 6.
Right. It's important actually what time. In the middle of the day is not what we're looking for.
No. That's interrupted sleep, and it doesn't really. I always tell my patients, the brain is like a computer that you are so attached to. It has to go through 5 cycles of sleep in order for that brain to, in a sense, reboot.
Right.
If you interrupt it with a 30-minute break in between that 2 to 3 hours, doesn't work.
Okay, so then in addition to that, you're looking at, again, very, very gentle products, non-drying, so no allergens, barrier repair, VCO and monolaurin, in case there are, other creatures there, mites or fungal stuff, that will help in part. But make sure also you're getting the right diagnosis. Sebderm can be misdiagnosed again because it can present as lots of other things.
And just remember that you have to go to your dermatologist because even with a patch test and a negative patch test, there's reasons for it. And I will delve into why it has become negative because obviously to my eye, the skin should be patched.
So we got cut off. And we were talking about seborrheic dermatitis. I think we answered that pretty well. We have another question from Shantley. Itchy, dry spots due to hot and humid weather. I also owed you this. Thank you for asking again. What products to use?
Can I leave that?
Itchy, dry spots due to hot and humid Itchy, dry spots due to hot and humid weather. Products to use.
You see, this is the kind of history a patient will come to see me. And then I delve into it some more. How old were you when you began to notice that you react to this? And then they'll give me the answer. Where does it really begin? Can you show me because during telemedicine, I have a frame of the parts of the skin. To be a proper dermatologist, you have to inspect the whole body. All right? So I asked them to take pictures of the various parts in a way that they will not be worried about privacy and all. By looking at, therefore, those spots, but in the context of the larger part, which is how is the rest of the body affected by those spots? Which ones came first? How did it look at the beginning? How does it proceed over time? What kind of medications seem to help, etc.?
So again, for itchy, my understanding is in the heat, it can become itchier, okay? But you kind of need to know what is causing it to begin with. Is there an underlying problem? So patch testing again to find out if it's something you're touching or exposed to or that you use in the shower. Is that causing the dryness to begin with? Then the itching is more exacerbated in the heat. Or do you have an eczema? So that there are cracks in the barrier and what is causing the itching is a secondary infection. So it's not as cut and dry as just use this and you'll be fine. If I were to suggest anything, pre talking to a dermatologist, you should see your dermatologist. But let's say that you don't yet. Again, very basic, allergen-free shampoo, conditioner, body wash, virgin coconut oil is very good for barrier repair and disinfection if there is a secondary infection, and monolaurin is what we would normally recommend.
May I interject now?
Sure, please.
Okay. Anybody who wants a copy, just tell her, and I will give 3 particular articles that address many of the things we're talking about. What led me into this is a study by Dr. Libol and his group across the United States as well, and then they jumped even to Europe, so it became both European and this was a questionnaire study on what do the patients think of us, dermatologists. And basically the summary of that multi-country and multi-nation study was that patients are not happy. We were giving them, as I told you earlier, biologics that clear them up very quickly and other stuff, steroids that are getting more potent and are good. And yet, bottom line of those surveys led by Dr. Libol of Mount Sinai is that patients are unhappy. They don't feel good enough about, So then the conclusion of those studies was that be more holistic in the way you approach your patients.
Yeah.
Look for one who can be holistic.
It's not just a cream or a shot.
Right.
We talked about this earlier. It's what you're eating, medications you're taking, how you're sleeping, your mental health, etc. I'm rushing ahead.
Your work.
I'm rushing ahead because we do have several things. Kat Albano, by the way, is our yoga teacher. She's on. I want to say hello. Talk about mental health and physical health. Yoga's awesome. Anti-inflammatory, fantastic. Cash Caparet. Thoughts on diluted, unscented Castile Soap as a facial wash for these conditions. I can actually take a stab here too.
Let me answer you very shortly though. Then the thing about like Doctora Laura, I told her to become a doctor. She wanted to become a vet instead.
And then I wanted to be a different doctor. I was going to get a PhD in cultural studies and stuff, so we could talk race and gender and power. But anyway, so diluted, unscented Castile Soap as a facial wash for these conditions.
Perfume is only one of the things that can produce contact and photocontact dermatitis. So there are several other chemicals, there, ingredients. We always mentally immediately look at what are the top allergens that he may have. Beyond that, there may be other allergens, there may be other ingredients that haven't made it to the top list of allergens that we test, and yet the patient's sensitive to it. So therefore, this is why I keep saying, please go see a proper dermatologist who will take care of it. And if they're into contact dermatitis and photocontact, even better, okay?
So on the Castile Soap issue, most soaps are made with a process so that they are more drying and denaturing to the skin than a cream or liquid cleanser. So at least for us, as a general rule, we never recommend soaps for facial cleansing. And certainly for conditions like eczema and psoriasis, where the barrier is already so compromised, we wouldn't do it. But check with your doctor, get a patch test, make sure you have the proper diagnosis, and make sure you're avoiding the right allergens for you. Okay.
One last thing about that, the patch test. If you go to a contact expert among the dermatologists, he will go beyond the patch test and do, for instance, product patch test.
Yeah.
Get the product, test it. If it's positive, they get in touch with the manufacturer and ask how is it done, beyond the ingredients, what was done to it, etc.
Okay.
So you have to look for this kind of a dermatologist if you have a very chronic, recurring, still using steroid after all of those years. Go to somebody who can understand what you are. So there's patch testing. First, IgE
Possibly
testing.
biopsy, IgE, and dami. There's a lot.
Those are the things that will have to be continued by your doctor.
For those who are joining late, we've already posted, because we got cut off, so we posted already our first half of this discussion on IGTV here, so you can watch that. I am going to now, the poor thing, be interjecting more because I know she's busy and we're running out of time. So I want to make sure we're here. Yes. Okay. Hi. We're back. So Maria JCLM. Parang I know this person, but I can't tell from the handle. Hi, Tita Verms and Tita Laura. So Tita Laura, so clearly younger. I have sebderm, but I've been experiencing chicken skin that becomes itchy after showering. Is this sebderm or chicken skin? Are they connected?
In a way, because probably you've been taking antibiotics orally, or using a product orally that has antibacterial antibiotics. What happens is our skin actually has its own microbiota, and at the hair follicle in the skin, there are what we call lipases. And don't let me get on that one. The organisms that are natural and normal in our follicles and skin are called malassezia, and the other one is a mite. Believe it or not, we have a very friendly mite who does things for us at the level of the skin. The important thing is that when you use too many antibiotics orally, topically, or in your soap, you are disrupting that balance of nature, bacteria and fungus. They don't not necessarily like each other, but they're there, right? And
there's a negotiated peace. There's a balance.
If you kill the bacteria, though, by antibiotics, often known for this, that, and the other thing, here's the fungus. It begins, its population becomes more and more. When that happens, when you perspire, which is the big question you were asking, when you perspire, those fungi can develop into little pimply things. If this is what you're talking about, the pimply things across the back, some are very severe, others are just little pimply things. But look at the pattern of where does it go, basically. Is it where the sweat comes down? Is it over here? Because you may be getting a folliculitis from the fungus, which looks like pimple. It's an acne.
Bottom line, if I may, you really need to see a dermatologist to make sure what it is to begin with, right? It could be a type of folliculitis, it could be a sebderm, it could be a fungal thing, it could be it could be an imbalance in the microbiota of the skin, and it could be exacerbated by contact derms, so patch testing would be helpful again. I'm gonna rush through because I know she has calls and stuff. I just want to get through two quick questions here. Three. Medications or food to avoid by psoriasis patients?
Okay, on a general scheme, which is an anti-inflammatory diet,
is what you want.
The anti-inflammatory diet addresses the inflammation that goes all over, including to your depression and to some
actually everything.
Everything is basically triggered by that inflammation. Like I told you, in acne, when you biopsy even the very most normal
acne
skin.
Na naman.
Okay, later na.
So, she's so obsessed because she's been reading about it. Cook with coconut oil, even RBD. Coconut oil is better than any other vegetable oil, pretty much. Fresh fruits and vegetables, as much as possible, overcooked. No junk food, just cut it up. Cut it out. It's called junk for a reason. No sodas. If you want to drink juices, juice them yourself. Nothing prepackaged. All of this is more anti-inflammatory and will help you in terms of food. In terms of medication, she covered this earlier, so you might want to watch the earlier IGTV, where there are medications that can actually trigger flares in psoriasis and eczema. So that is the kind of thing your dermatologist will have to look at what you're taking to see what might be causing it.
Those include hypertension drugs, some diabetes.
That's right. She mentioned neuroleptic
drugs.
Okay. So, is psoriasis now curable or just manageable?
There's actually a new term that I really love about psoriasis. It's called mutation. they've been showing that by using these drugs, especially the newer coming ones, the skin is actually mutates to a less inflammatory level. I'll give you an example. I've been using biologics in the Philippines about 15 years. They've been progressing and getting better and better and better. And the latest ones that are available here in our country, there are many more abroad, are called ustekinumab and secukinumab. And what we've shown in my clinical experience and in new studies being done by Novartis in particular, they found out, now they agree with me because over the years I don't use the guidelines for the use of biologics the way the people, I said, my guideline is my patient. So I may take a look at that, but my guideline is my patient. Among those patients, I've told you earlier, they can be taking the biologic for a whole year after I give it before it recurs, rather than for me to give it every 3 weeks, every 3 months.
Also because they're expensive. So,
exactly. So people who cannot afford it are able to afford it and are smiling, have quality of life, go back to work.
And again, it's not just one thing. You got to look at the whole thing.
That's the important part.
Okay, last few questions. How can pregnant women like me, because Bianca and Daya, manage eczema flare-ups?
You're pregnant, so basically you would like to be using something that is just external and not any of the drugs that have class and for the baby.
Okay.
So topical. Use
topical and gentle, anti-inflammatory but non-steroidal. I can get into that a little bit later. What product best for eczema? I will tackle in a bit. Do all dermatologists have patch testing? No, but you can look, if you're in the United States, you can go to contactderm.org and there is a directory of doctors who patch test. In the Philippines, I believe if you go to the PDS, I don't know if they have a directory for patch testing doctors, but they do have a contact dermatitis subgroup in the Philippine Dermatological Society, and they do patch testing. And we do as well in our research clinic. So if you're interested in that, drop us a DM.
Fly to the Philippines, we'd love to see you.
We also do teleconsultations with her and other doctors, but DM us for that and we'll hook you up. Last question, and then I will say goodbye to her so she can continue researching and with her calls and stuff. Is skin asthma an eczema?
Yes.
There you go.
It's little bubbles first. Yeah. We do a biopsy and we'll see those little bubbles. As we do another biopsy, if I were to do another biopsy in, say, another month, it'll change. It has now matured a little bit. So the little tiny bubbles in the epidermis have now become larger bubbles, larger locules. It's during these phases that it's wet and, oozy and crusty. Then becomes thicker and crusty. That's the later stage. So, did I answer that question?
You're awesome all the time. I can't even tell you anything just because you're so great. So, in closing, they're all inflammatory conditions, right? Psoriasis, eczema, and sebderm, no, they're not the same thing. Can you have them at the same time?
Absolutely.
Yeah.
Before, we used to think that if you have Th1 and Th2, that, disease, you're atopic and that's all. We've also found out a fascinating case I had of a military guy way up on top, and just the hands and feet for many years. Much later, they diagnosed him as psoriasis. But I said, let's go by that history of years having intestinal palms and so on. Actually went to his, I told him, give me a picture of your bedroom. Give me a picture of the house, of the things that you're using. It turns out he was sensitive to, guess what? Rubber and leather.
And feet.
All I did was say, okay, this is what you're going to do. You're going to buy this, you're going to buy that, so you don't get in direct contact with your shoes. And voila. And then I gave a biologic.
And again, the whole lecture, sleep well, eat well, mental health, etc. Okay, so again, all inflammatory conditions. Psoriasis tends to present as scaly, dry plaques. Tends to start on the scalp. You can also start seeing it in the nails. Eczema is a descriptive term. Bubbles form, they then crust over. Eczema can be atopic dermatitis, nummular dermatitis, or an eczema caused by contact dermatitis. Patch testing tends to help all of these conditions because at least you know what to avoid. Other things that help these conditions are things that help the barrier of the skin repair. So really rich, nice humectants on the skin that provide barrier repair. Virgin coconut oil is one of them. Monolaurin is another. Barrier creams that actually, are like physical barriers against other things. Allergen-free is helpful. For psoriasis, biologicals can also be extremely helpful, but it never is a one-shot deal. You do have to look at an anti-inflammatory diet, sleeping well, maybe seeing a psych derm, dealing with your mental health, and prevention. Most importantly, do not self-medicate. Steroids are important, but not for maintenance, not for long-term use. Get a proper diagnosis and be managed properly by your dermatologist, because you might also need blood work to monitor inflammatory markers and whatnot. Anything else you want to say before you go?
I always end up with recognition of those who taught me. I'm teaching to you and hope you will spread the word as well to people who want to know about it. The people I'm very grateful to are on contact dermatitis is Professor Franz Storrs of University of Oregon. She's retired now, but was a fantastic teacher. That's how I'll cut my teeth on. At Cleveland Clinic was the very first with Dr. John Hasrick. Henry Rennick was there at that time, George Curtis, and Hazard gone. Besides that, then, they stimulated my interest in immunology and in contact dermatitis. Then I got to meet and become good friends as well of two people who I love dearly because they've been my mentors. Is Chito Cruz, Dr. Pochado Cruz of University of Texas Southwestern, as well as Dr. Paul Bergstresser, who was chair of the department for a long time. If you find any dermatologist that's in contact dermatitis and was trained by those three names, go to him quickly.
Okay, folks. She will go now. I will talk very briefly again, those who were asking about product questions. Thank you. Love you. Mwah.
Bye, everybody.
She's working on research now, so this is always basically me begging her to come and talk. So very, very briefly, guys. Someone was asking, is Illuminance toner also good for acne? And the simple answer is it won't hurt. It's non-comedogenic.
It's good for people who actually hyperpigment, right?
Yes, it's good for people who hyperpigment. For people with acne and hyperpigmentation, we actually recommend both ID and Illuminance. ID is salicylic acid, and it's wonderful because it's a keratolytic in the skin. It helps microexfoliate in the oiliest areas of the skin. So that's really great. Now, in terms of people who are asking the products that we recommend, normally what dermatologists recommend for people with eczema and psoriasis is our Essence Clark Wash and Conditioner, because they're both allergen-free, extremely gentle on the scalp, and for body cleansing as well as the hair. A nice technique my mom likes for people with really bad scalp, sebderm or psoriasis or other issues is to comb Boo Boo Balm through your scalp first, then do Clark Wash and Essence Conditioner. For facial cleansing, Moisture Rich Creamy Cleansing Milk or Red Better, this is actually the moisturizer, but Red Better Cleanser are the two things we normally recommend for the same thing. They're really great for dry skin, they're barrier protective. And then moisturizing, she talked a lot about humectants that are also barrier repair. So we would start with a daily moisturizer in either the Mommy Coddling All Over Lotion or the Essence Hand and Body Soother, which can be used on the face as well, because they both have virgin coconut oil and monolaurin and are allergen-free and light and wonderful and feel great. But again, because of that barrier issue and the potential cracks in the barrier and the potential for secondary infections, we always say follow the moisturizer, the lotion, with virgin coconut oil, either Know-It Oil, which is pure virgin coconut oil, or Oil as Well, which is virgin coconut oil plus monolaurin, right? So again, head to toe cleansing is Essence Clark Wash, Essence Conditioner. If you need, put Boo Boo Balm first on the scalp before shampooing if the scalp is reacting at the moment. And then Moisture Rich Creamy Cleansing Milk for the face, or Red Better Cleanser. Grandma Mini Mommy Coddling All Over Lotion or Essence Hand and Body Soother for moisturizing, followed by know what oil? Virgin coconut oil, or oil as well, which is virgin coconut oil plus monolaurin. For sunscreen, we would recommend the purely inorganic or mineral sunscreens like Armada Baby or Armada Post-Procedure, which are both also barrier creams. They're thick physical barriers to protect that damaged barrier of eczema and psoriasis even more. And for flares, don't ditch your steroid just unilaterally. Steroids are important and you might need them, but they aren't for maintenance use. Long-term daily use can be really damaging. So if you can, talk to your doctor about Boo Boo Balm for flares and Red Better Calm the Heck Down Balm for something that's really red or itchy before you reach for a steroid. Okay? You can shop for any of this stuff on vmvhypoallergenics.com internationally, or in the Philippines, vmvhypoallergenics.ph. And don't forget to follow us on Instagram and Facebook and YouTube. And our topic next week will be, which my mom was really getting into already, as you heard, acne. We'll be talking about acne next week. So please remember to mark down in your calendars. That'll be Friday at 9 a.m. in the Philippines, which is Thursday, 9 p.m. Eastern Standard Time in the States. If you would like a teleconsultation with my mother or another dermatologist at VMV Skin Research Center and Clinics, you can DM us here and we'll hook that up. Remember, you can send us your patch test results and we can customize recommendations for you based on your particular allergens and possible cross-reactants. If you need a patch test, in the United States, you can look at contactderm.org, and in the Philippines, look at the Philippine Dermatological Society and the Contact Dermatitis subgroup. I don't think I've missed any important questions, and thank you so much for joining us today, and have a wonderful, wonderful day and a wonderful, wonderful evening. Thank you. Bye-bye.